Sorry about that, we just seemed to drop out. So I'm Dr. Janine Bycroft, those of you that are just joining us, and Giresh Kanji is our musculoskeletal pain specialist here to talk with us tonight. So Giresh, we were just about to start talking about chronic pain and the difference between chronic pain and acute pain. Can you just explain that to our viewers and what each one is?
Basically, acute pain we've all experienced. We've basically all fallen over, twisted our ankles possibly. And the thing about acute pain is that we will often rest, we might put a bit of ice on it, maybe take a few analgesics such as Panadol or some anti-inflammatories, and it lasts a short time. And we can cope with that really well. And I think most of us have experienced that and we get through that. The problem really lies in when pain is there every day, 24 hours a day, and once it goes beyond a few months, and we define chronic pain usually as over 3 months duration, and sometimes some people define it over 6 months duration. And once it's at that length every day, it becomes very annoying. And changes occur as well. Pain tends to increase in terms of the intensity. It also tends to increase in terms of spread the longer the pain is present. And sometimes the longer the pain is present, and I've seen people with chronic pain for 30 to 40 years. And when it gets to that stage, people don't really have answers. And so there's a lot of distress associated with chronic pain. One of the main problems with chronic pain is that pain basically elicits a stress response. So basically we have 6 stress chemicals in the brain, 2 in the spinal cord, and 3 in the body that get released when we have pain. And this basically changes the acute pain picture to chronic pain, as well as symptoms such as insomnia, anxiety, depression, irritability. And it's not really just the pain creating these, but also the lack of answers. And then people worry about their jobs. People also have this overwhelming feeling that they're the only ones. They don't really have a lot of exposure to other people. And I know I had back pain for 2 years. Every day I was waking at 2 a.m. after an accident at the gym. And I just remember talking to people, and even close family members, they don't really get it. And you sort of, they'll look at you a bit blank as, oh, what's going on? What are you feeling like this for? And I think that's one of the things I often say is, unless you've experienced it, it's hard to get a real empathy for it. And hence many people with chronic pain won't get the level of empathy they may wish for from perhaps health providers, perhaps their family, etc. So I think it becomes a very isolating condition.
Oh, working as a GP, I've certainly seen lots of patients over the years with chronic pain and the huge impact it has on their well-being and their emotions and their irritability, the depression, as you say. And it's sort of almost easy when you've got a broken arm. It's obvious that you've got something wrong with you, but when you've got chronic pain, those acute symptoms are gone and you actually look okay.
And I think taking that theme a little further, fibromyalgia is a condition of chronic widespread pain that's present with symptoms like insomnia and poor sleep and fatigue and sometimes depression. And there was a study done, and it's a very interesting, simple study, but they studied people with motor vehicle accidents, and what they found was that if you fractured your leg, your chance of developing fibromyalgia over 3 months was about 2%. If, however, you experience whiplash and neck pain, it was around 20% or more. So those ongoing pains that we don't have very good treatments for, that carry on, tend to lead to this chronic pain type of thing. Whereas the fracture, we've got pretty good answers for, and it only in very few cases will it lead to chronic pain.
Okay. So for acute pain, you've mentioned some of them, but what would be some of the common sort of tips and advice that you would give someone that might be useful?
I think acute pain's very different in that often with acute pain, I'll take the ankle sprain, I think we'll go with that, it's a simple thing. Basically, once you sprain your ankle, you'll find you'll often get swelling, it might get a bit tender, it might get hot, and it'll often be painful when people are walking. And sometimes people, if they're walking on the flat, they don't get too much pain, but as soon as they're on uneven ground and they're stressing their ligaments, they'll get pain. So with any acute pain condition, it's a good idea not to stress the part that's painful and cause pain. So, if you did have an ankle sprain, you wouldn't want to go back to running immediately. You're better off perhaps going swimming. And so you need to modify activities while that natural history heals it. And I think this is where people are getting a lot more sort of savvy, especially in professional sports, where they're standing people down for concussion and other injuries until they've healed relatively fully. Because the worst thing you really want to do is keep aggravating the actual trauma and the damage that's occurred, because that will delay healing.
Okay, great.
I think, as well as that, the standard things such as the ice, taking some analgesia, are obviously appropriate, and getting advice as well. I think quite often people need to go and see a physio or another health provider just to get the advice on what people should and shouldn't be doing, and any exercises that may help them.
Okay. And the ice, how often should they do icing for a sprain like that?
Look, I'm not up to date with the with sort of icing, but I suspect a couple of times a day for sort of. With ice, you've got to be where you don't burn it, so you need to wrap the ice pack with some tea towel or some material, and then I would probably apply it for 10 minutes, maybe a few times a day. But I'm not 100% aware of the latest findings, which would be evolving in the sports field.
Okay, yeah, for sure. So then, thinking about chronic pain, what would be some of the sort of common tips and advice for reducing pain?
I think with chronic pain, we have to look at the, firstly, you may have an injury or a structure that you've damaged with an accident that's gone on for a long time. And as I said before, as it keeps going, your stress chemicals build up and they give you stress-related problems. And as part of my PhD, I in fact looked into what happens, and the stress chemicals that get released, in fact, attach to the brain pain switch and directly can increase electricity.
Right.
So one of the things about pain is most of our sensations are due to little amounts of electricity in our brain, usually our sensory parts of our brain that experience sensations. And it's like migraine. People with migraine, we know, are sensitive to light, sound, pain, touch, and smell. And one of the reasons is they've actually got channels in their brain that open up much more quickly. And in fact, people with migraine are more subject to chronic pain conditions. They have 3 times more all musculoskeletal pain. They have 6 times more fibromyalgia, and they have twice the incidence of low back pain. So that electricity in the brain then can also be added to by stress chemicals. So once the stress response occurs, I think people need to take action and do activities and things that will reduce stress chemicals in your brain.
So if you're one of those people suffering from headaches or migraines, what should they do? Well,
in the literature, and I'm currently writing a book on insomnia, anxiety, depression, looking at stress and how to alleviate the sympathetic nervous system, which is our stress nervous system. And the things that have been researched include exercise. So for exercise is quite a big one, and I think we all know that when we exercise, we feel better. And the studies generally show that if you exercise for around 20 to 30 minutes, in activities which increase your heart rate, such as about 50% maximum heart rate. So one way I say this to patients is that the stress chemicals are generally designed for the tiger. So you see the tiger, they go up, and you run, fight, sweat, they go down. That's sort of what I tell patients. And if you see the tiger, you're not really going to walk away. So walking doesn't generally reduce the sympathetic tone or the stress chemical tone in your body as much. And hence I say do an exercise for 20 minutes that basically you feel your heartbeat and you may be sweating a little bit. So you're sort of simulating a little bit that fight-flight response. But more importantly for chronic pain sufferers is that, and I see a lot of people with hip pain, back pain, knee pain, and the important thing is not to load the structure that gives you pain. And so if you have hip pain or knee pain, you may want to swim. Sometimes I get people just to walk up and down the swimming pool, waist height in water. And that basically will increase their heart rate, give them resistance, and give them a workout. Sometimes people with low back pain, sitting can sometimes aggravate pain, as people know. So sometimes using a cross trainer is a lot better than sitting on a cycle for long periods of time. And I personally, with my back, I use a cross trainer 20 minutes, 4 times a week, just to ensure that I get my workout, and this seems to help, and I don't experience any back pain. So exercise is certainly one. Now, what the last 3 years where I've been researching this new book is that there's several other options which people can adopt. One of them is heat in the form of a sauna, steam room, hot bath, spa pools. Basically, saunas have been proven to reduce the stress component of your brain and body. And in fact, for my PhD, talking about headaches, I did a randomized control trial looking at sauna 3 times a week for 8 weeks for 20 minutes each time. And we had a population with 16 years of pain, headache pain, chronic tension type headache, and they had pain for 24 out of 28 days on average from a headache diary. And we found that basically the results showed 76% reduction in headache index. And half the people were in fact cured from attending the sauna. It was a small study, but it was just to see if this concept would help. So heat is extremely good, as most people know, for chronic pain. Not so good for acute pain. And I think people need to distinguish that, because in the acute setting, heat might increase swelling, increase pain. So there's exercise above 50% maximum heart rate. There's heat in the form of sauna, spas, steam rooms. Then there's also yoga, tai chi, and meditation have all been proven to basically reduce the activity of the stress brain. So, and generally speaking, these things need to be done about 3 or 4 times a week if you're going to do the exercise or sauna or heat, and probably 4 or 5 times a week if you're going to go down the meditation, yoga, or tai chi avenues. So these habits are very good for us, and I think generally speaking, if more people did them more often, we'd probably have a lot less distressed people with chronic pain.
Well, I've certainly seen a lot of patients becoming more interested in mindfulness.
That's certainly another avenue, and I think the first few things that I mentioned basically can reduce the activity of the stress brain, but then I deal in a biopsychosocial model, and I think the first few things like exercise will help the biology of your brain and stress nervous system. So, and then you're right, the psychology is important too, because we often develop traits. We catastrophize sometimes. If something's gone wrong for a long time, our health is not great, we're not sleeping, we'll sort of think the worst. And I think we'll think, oh gosh, I can't do anything because I'm in pain. And so there's a lot of behaviors, and sometimes it might rekindle old things. Oh, I'm worthless, I'm no good, this has happened to me because I'm no good, rather than it's happened to me because I fell over or something a little bit more real. And so that's the psychological side of things. And you're dead right that one of my big things is to send people to mindfulness. And the reason I do that is I'm a big believer in fixing yourself, and I don't heal anybody, but basically I can hopefully advise people on, hey, this is possibly the source of your pain. These are some things that will probably help you in the long term. And I think as therapists or individuals in the health field, we see people for a very small period of time, and it's really probably what they do the other 95% of the time that will determine their health outcomes, and I think this is very important. So I would send many of my chronic pain patients for mindfulness courses, and the good thing about mindfulness is that you can go once a week for 12 weeks. It's $100 odd, so it's not generally too expensive, and you learn skills such as staying in the present. So, and a lot of us will worry about what's going to happen tomorrow or in the future when it may never happen, but we've spent a lot of time worrying about it. And the other thing is we'll often worry about what's happened to us in the past, and that's gone. And I think the more time we worry about that, the less time we have in the present moment to actually enjoy things that are pleasurable. So I'm a big advocate of mindfulness, absolutely, Janine. Yeah.
And that support from family and friends is really important, isn't it? And actually taking time to smell the roses or take notice of nice things, isn't it? And
I think
sunsets
I've sort of the biocycle and the social is the last sphere. And I recently read Johann Hari, Lost Connections, which you may have read. It's an excellent book, and it goes. It talks about the social connections that influence depression and how loneliness is a big part of depression. And indeed, I think when we do interact with friends and we get together once or twice a week, it makes us feel good. And that actually feeds back to our psyche and feeds back to our biology and actually reduces stress chemicals. And the research shows that joining a group basically is as good as stopping smoking.
Wow.
So it's an extremely effective habit. And I think this is something that, chronic pain, insomnia, anxiety, depression, we need to sort of have the message out there really that you want to change your biology, basically look at your psychological beliefs, and then you want to look at your social world and really get out there as well. And I think people who change their biology and basically reduce their stress brain over sort of 12 weeks, once the brain becomes uncluttered, it becomes easier for them to process things and to create new habits that will then continue their journey to better health.
Well, that really fits in, doesn't it, with some of the chronic pain websites, and there's also talk about retraining your brain, don't they? So it's all those things of connectedness and relaxation, mindfulness.
Absolutely, I think, and as I said, I'm very interested in self-treatments, and along this line, one of the simplest self-treatments to reduce the stress brain is breathing. And the studies actually show that if you breathe 5 seconds in and 5 seconds out, about 6 times a minute, that actually reduces the activity of the stress brain. So there's studies out there showing this. And so the simplest form of meditation would be to lie on your back, put your hand on your tummy, and basically just breathe 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. And if you did this over 20 minutes, and you don't have to meditate or do anything, the counting is fine, that will relax you quite significantly over 5-10 minutes.
Right, okay. Well, look, that's some great tips for us. Thank you for that. Some question. We'll just take the question.
We've got some questions from the audience. Can we say their name?
Yes.
Okay. The first question was from Rachel Olson, and I was wondering, why don't you read it? Otherwise I'll do all the talking. Sorry.
Yeah, I'm going to pick up. I've got to get my glasses on.
Oh, that's right. Okay. So the first question asks, I was wondering what your opinion is on prolotherapy for craniocervical instability. Okay, that's a bit of a complex question, but I think I can add some light to that. I think firstly we need to look at this concept of instability, and especially in the neck. And I know in some places, particularly in Auckland, they often do flexion and extension views of the neck. And they're sort of looking to see whether one bone will slip on another.
Right.
And that's probably the most medical form of instability. I don't know. There's other types of instability that may be out there in other health fields. And often they're called dysfunction. So sometimes that can be whether the joint is a bit stuck, and you may have that clicked, and sometimes, that's sort of a term, the dysfunction may be a better term for that. But when we talk about true instability, I don't see it very often at all, actually. And I don't really, in all the x-rays I've seen with flexion extension views, I've seen very, very few cases of instability. And so I don't think instability is probably the term to use in most cases. So, and I can really only talk about the medical case. So the instability is like if you bend forward, will one vertebrae slip forward on another? And that's very, very unlikely. and in fact, I don't see that very often at all. And sometimes actually there's this thing in the low back where people's vertebrae have slipped quite a bit sometimes. And this is called spondylolisthesis, if you want to know the technical term. And quite often people have a slip of 10%, 20%. They have no pain often. So, you know, and so that's one side. So I think instability is not a great cause of musculoskeletal pain, although if you have it and it's severe, it can cause a lot of pain, but it's not a common cause.
So that leads on to the question about, in your book, Fix Your Neck Pain, Headache and Migraine. You talk a lot about when having your head forward and the pressure that's on your head.
So let me talk musculoskeletal pain in general, and I'll give a 2-minute overview of it. So I like to describe to patients that there's no two bones in the body without a washer. And I think that's quite nice, simple. So the washer can be a disc in the spine, it can be cartilage. Now what happens as we, not as we age usually, but as we have accidents and falls as children or adults, we basically may damage the washer a little bit. Then what happens is when we produce pressure, basically electricity can form here in the joints and go to the brain, and we perceive this as pain. Now the simplest thing is the knee. Sometimes I've got a little bit of arthritis in my knee actually, and so the washer's a little bit damaged. Now if I go for a 10K run, it swells and it becomes very painful. But as I'm sitting here now, I've got absolutely no pain. So quite often we can understand this sort of concept that pressure can create pain depending on our structures in our body. I'll talk about that in a sec.
Yeah.
So basically the overriding thing with musculoskeletal pain is that it is subject to gravity, and it's often biomechanical in flavour. Now, I'm going to talk about cryotherapy in a second to answer that question, but I'd like to just explain this. And it's quite different. So if I've got knee pain, I walk, it hurts, I sit, it doesn't. So that, I would say, is a clear defined musculoskeletal pain with a biomechanical flavour. And Janine, that's easy to understand for most people. And when we get to the spine, for some reason we get a little bit hazy about this, but basically if we have washers in our neck and our back that get a little bit narrowed, and the same thing we could imagine may happen. If we put lots of pressure on them, we might be creating electricity that goes to the brain and creating pain. So this comes back to the neck. 5 kilos when we look straight ahead. And in fact, the measure is 50 newtons per second. So it's 5 kilos times gravity, which is 10 roughly, and that equals 50 newtons per second when I'm looking straight ahead. And so if I look straight ahead for a minute, that's 3,000. Now, if I look down, every 10 degrees I look down, my head weight doubles on the back of my neck. So if I'm looking straight down, it's 50 kilograms, and that's 500 newtons of pressure per second on my lower neck. So you can see the numbers stack up very, very quickly. And give me the phone.
Yeah. Well, it's a common position, isn't it, these days, for the young people around?
Basically, in 1 minute, you'll increase your pressure on your lower neck significantly. And 90% of neck problems occur in the lower neck between the vertebrae 5, 6, and 6, 7. And that's why. That's because they get the loading all the time. So all the punters out there that are going like this with their phones, you really want to put the phone up here, because if you keep going like this for ages, you are really going to get a sore neck. And over the past 6 years, 10 years, I see just as much neck pain as I do back pain now. And I think the first thing people need to know is about posture. Absolutely, posture is vital. So I suspect that there'd be more neck pain created from looking down than actually instability.
Right.
And in fact, the other things that can happen are that the shape of your neck can change. It can actually change. And if I may just pick up a picture, I think it's while we're here. And I think this is the sort of thing people need to know, that the shape of the spine, I consider it to be like plasticine. It takes the shape you give it. So Okay, that's enough. I'll explain it. Yep. So normally the shape of the neck is a C shape like this, and your head sits here, and it operates like that, like a C-shaped spring. Now, if you're looking down all the time, it can straighten, and when it's straight, the pressure goes straight to the bottom, and it's sort of, there's no spring. And sometimes it can reverse, and that creates even more pressure down on the bottom neck. So it's a vital. The pressure's probably more important now. Prolotherapy is where a glucose solution is injected into ligaments, and it's very common, and the studies show that it's reasonably good. And basically, there's some theories that it may strengthen ligaments, hence the thought that if something's unstable, because the ligaments are loose, if you inject prolotherapy, it may strengthen the ligaments. I don't know a lot about it, but I've certainly read a lot about it. I doubt very much it does work by actually strengthening ligaments. I'm not sure, but it can alleviate pain. That's almost certain.
And how long does it benefit last?
It really depends. I think there's a lot of controversy, but often injecting things into muscles or around the skin or under the skin can help, and often they help myofascial pain. And it really depends if myofascial, and that myofascial is muscle type of pain, just slightly under the skin. It's best to think about it like this. If your tissues under your skin and the muscles are the source of your pain, and you do treatments to the muscles, such as massage or acupuncture or injections, and it goes away completely, then one might surmise that the pain was coming from that area. I think if the pain comes back in a few weeks or a few months or whenever, then quite commonly in chronic pain, the pain is in fact coming from underlying joints, discs, and other structures, and often spreading to the muscle. So I think that's, in pain medicine, it's really about excluding things. So and excluding structures. Any structure with a nerve supply can create pain, and this includes muscles, ligaments, some parts of the discs, the bone. And so it's really about looking at a variety of structures. And I think common sense would prevail that you might go for some simple treatment first. If it doesn't work, after a while, you may need to go to more complex treatment or investigations.
Okay. So that actually leads on to a sort of common scenario. We had a question about John. He's been gardening and digging over the weekend, and Monday morning he's woken up with real sort of ache in his back and feeling, a lot of us have all been there and done that. What would sort of be the general advice in that sort of scenario?
What I'd tell John is that it's quite common to have episodes of low back pain. So normally speaking, you may have back pain, and then you're probably likely to have 1 or 2 episodes a year, sometimes for many years. And usually it'll be on loading. So if he's been gardening all day, and it's quite often the weekend warrior, spring is in the air and they want to weed and mulch the whole garden all at once. So they spend the whole day in the garden, and they come out the next day and it's a little bit sore. And so it's a very common scenario. And in this situation, you would say to them that probably 90 to 95% or more will be better, probably within about 4 to 6 weeks. And actually, it doesn't matter too much what you do. And there's even some research. There's a very, very good trial in Sydney that looked at Panadol for acute low back pain. And they found that it was no better than taking no Panadol for acute low back pain, because everyone basically got better. And they got better quite quickly. So I think the natural history of anyone with acute low back pain such as this is that it is going to get better. And I would probably, for the first few days, wouldn't do too much heavy lifting. I think that's probably sensible, especially if there might be a disc in the back causing a few symptoms. You certainly wouldn't want to aggravate the pain. But other than that, carry on, do most things that don't hurt too much. And as I said, if I wouldn't stop exercising. I would just modify the exercise for the period that you're in a bit of discomfort. And take some analgesia if you've got some, because it may help. And the other thing about painkillers and things is that there's no hard and fast rule. We're all different, and our brains are all different. Our receptors are different. So someone can respond to something and it just takes away their pain. Someone will take the same thing for the same condition, it will do nothing. So I think if you're taking simple analgesics, Panadol or some anti-inflammatories, I probably wouldn't frown upon it, and especially if it does help your pain, that's pretty good.
Okay. I mean, as a GP, if I see someone with back pain, we go through our red flags.
Yes.
Do you want to just explain to our viewers what the red flags are?
Red flags are sort of herald conditions that are more severe or more dangerous, I suppose, and are likely to cause problems, sometimes life-threatening problems. So, has the patient got cancer? I mean, obviously, and for that, we might ask the patient, there's certain demographics. If they're maybe over 50 or 60, they're in an age group that they're more likely to get conditions like that. So we might ask them, have you had any weight loss lately? Have you been feeling really unwell? Or is this just a backache that's lasted a couple of days from lifting in the garden? And so there's a few other conditions. I think we're not quite talking about fractures here, but if someone has fallen recently off a meter or two and landed on their back, we'd certainly want to exclude fractures, because we certainly wouldn't want anyone to be walking around with pain and doing activity and getting treatment when there's an underlying problem. I think that's quite important. If someone's having sort of severe pain, and sometimes if there's maybe a slipped disc and having pain down their legs with pins, needles, numbness, tingling, that's quite severe. And I often tell patients, imagine hitting your funny bone. And so when you hit your funny bone, what you're basically doing is hitting a nerve, and you feel this sort of nasty pins, needles, sharp shooting pain. Now imagine leaning on your funny bone with all your body weight for a few days. That's the sort of sensation that a slip disc pressing on the nerve can give you. So, when people are feeling that amount of pain, they're going to be in a lot of distress. And I think that also means that they should be referred on for investigations or managed slightly more than the weekend warrior who has some pain. So I think intensity of pain is not a red flag in itself, but I think often with some conditions you'll get much more pain. So that it probably needs to be treated slightly differently.
And the other one we tend to ask patients about if they've got any bladder or bowel symptoms, isn't it? Are there any other key things?
Of course, I think with bladder and bowel conditions, sometimes when a slip disc can sometimes affect nerves as they come out of the back and low in the spine. And these nerves control bladder, bowel function. And I think really once they've got that, they've usually got a lot of pain. So usually I think if someone has quite a lot of pain, they're in obvious discomfort where they're sort of lying down in your consult room. And we get this quite often. We get patients that come in and they lie on the ground because they can't sit. Fairly easy to spot that. And I think if that's the case, then that patient needs to be worked up, I think, probably quicker than later. Because if that patient comes into, the consult room in general practice, say, and lays down on the ground, they're in a lot of distress. And the other things that are going to happen is, they're probably not going to get to work. They're probably going to be miserable. They're really not going to sleep that well. And they're going to be prime candidates to develop chronic pain. So it's almost like, the longer the pain is there, the more it gets entrenched. So if we can sort of get a diagnosis relatively quickly and then try and match the treatment to the actual problem and give them analgesics and other support medications that will help them. And sometimes there's injections and other things too that can be offered, but I think that's probably quite important, that we certainly don't want to make those patients into chronic pain patients if we can avoid it.
So that would be one of the key messages. If anyone has got lower back pain and they've got any incontinence, urinary or bowel incontinence, they should get seen immediately.
Absolutely.
And if it's in the weekend, you just go to the emergency
That's
department.
right.
It's one of those few scenarios where it's like,
That's
take
right.
action right now, isn't it? Okay.
It's not, weirdly, it's not something I've seen a lot of in the 15, 20 years I've dealt with just chronic pain.
Right.
In fact, I perhaps once or twice.
Right.
So
it's rare.
It is rare,
Yeah.
and it's often probably seen at the hospital too. So I think the hospital is the place to go if you ever have bowel or bladder incontinence, no matter what the cause is, I suspect, but especially if you've got backache as well.
Now, another common scenario is muscle spasm.
Mm-hmm.
And we've all seen people that are just so in terrible pain from back spasm. And it can come and go in a very short time, or it can hang around for days. What's the best options around managing that spasm?
As I said previously, the muscle spasm and chronic pain, I think heat is easy. I think that's probably, most people probably do that. Heating up a wet pack or a hot water bottle, or sometimes you do get the electric small blankets, and that's quite a nice thing someone can do at home. I think it's probably worth looking at, so if we're talking about the back, I think that's probably a common source. We need to look at posture as well. And what I mean by posture, and I'm going to sort of demonstrate, hopefully we can see it on my seat. So I'm going to bring my seat on. Now, if I sit like this away from the back of my chair, I've actually got 50 kilograms or 500 newtons per second sort of going downwards. And so, if you find you sitting yourself like this, and you get a bit of spasm, it's probably not a great way to sit. Now, if I sit like that, that's actually 275 kilograms or 2,750 newtons of pressure on my low back discs. And now, if I sit like this, my body weight is actually going through the back of the chair. So I'm reducing the pressure on my discs. And what often happens with people is that their muscle spasm often heralds things that are going on inside the body. They may have some disc or joint or other problems. And so, and obviously we can test this sometimes, like if you treat the muscles and their pain and spasm goes away, we're fine. But if it doesn't go away, then there may be underlying issues. So I think people need to experiment with positions. Sometimes they might want to try sitting to the back of the chair, or perhaps reclining. Okay, we've got another question here. Not at all. That's fine. And I'll read the question out. I'm a long-term migraine sufferer, migraine without aura. My triggers are hormones, stress, adrenaline, alcohol, and lack of sleep, amongst other things. I've come off the contraceptive pill to try and conceive. I was wondering what his thoughts on migraine treatment during pregnancy and ideas for hormonal migraines instead of the contraceptive pill. That's a very good question, and one that's I'm interested in answering. So I think when we look at some of the triggers, I developed a model in my PhD looking at the triggers for chronic tension type headache, which are similar to the triggers for migraine. And when we look at a lot of them, they actually increase the stress chemicals in your brain. The sympathetic nervous system tone goes up. So alcohol's one. So many of us have experienced a hangover. And what's actually happening is the alcohol is basically increasing stress chemicals pretty much in your brain, in the part of your brain that feels pain overnight. And as they build up, you suddenly, when you wake, you've got a hangover, you've got a headache. It's nothing to do with dehydration. And I go out on a limb here because when you read all the headache studies in the world and migraine studies, migraine is least common in Africa. And it's most common in Europe and intermediate in Asia and America. And so if dehydration was a significant cause of headache, I would certainly expect it to be most common in Africa. But it's not. Now, so have a think about that. And that's why alcohol is a trigger for headache and migraine as well, because it's sort of, in fact, the studies show that 1 glass of wine sort of relaxes, but 2 or 3 glasses, your sympathetic nervous system, which is your stress nervous system, tone increases.
Right.
So that's what the studies show, and hence it's a trigger. Stress, obviously, any sort of stress triggers a stress reaction. And basically, as I said before, that the stress response, the fight-flight response, is designed for the tiger. And our past, where we're finding tigers and hunting, and basically they go up, but they also go up in any stress response. And we know this if we've had an argument, a big row with our partner or friends, 15, 20 minutes later, we'll sort of feel a bit on edge with butterflies, and sometimes we'll feel our heart racing, and then we sort of will come down after 20 minutes. And most of us sort of experience that. So we're having the release of adrenaline for stress. So that, and lack of sleep as well. And sleep is an extremely important one. But when we go to sleep for 6-8 hours, our stress pathways in our body and brain basically do a complete flat line, and then they come up again. So when we do sleep well, we're actually totally improving our whole stress balance. Right. And if we don't sleep well, we're not really getting that dip in our stress system. So, and that's why most of us have a headache if we haven't slept, or we're doing some traveling and have had jet lag. It certainly is a trigger for migraine headache. Now, the hormones are an interesting one. And in fact, the hormones are probably the sort of least factor, the sort of not the major factor amongst the others, in fact, for creating headache migraine. And so ideas for treatment during pregnancy, I think probably, as I said before, I would certainly look at exercising 20 minutes. And that reduces the stress chemicals in your brain. And the evidence, the randomized controlled trials, which is our strongest form of evidence, basically shows exercise reduces headache pain and migraine pain. And in fact, it reduces as well as our medications we use for prevention. So it's not just a good idea, it's about as good as we've got. I think looking at meditation, yoga, Tai Chi, meditation, yoga, Tai Chi, and heat is a possibility, although some people are heat intolerant, but having a hot bath may be helpful. So I think those are the sort of treatments I would try and look at. Now, also with headache and migraine, quite commonly the trigger or the pain is often from the neck for many people, and it refers into the head. So having a look at some of the head postures in terms of, not looking down too much. And I see a lot of women who have given birth and, their children 2 or 3 years old, and they come with headaches, migraine and neck pain, because obviously you are looking down a lot when you're feeding infants and things like that. So I wouldn't be surprised that these may actually get worse once you've given birth, A, due to the lack of sleep from the newborn, and B, perhaps from posture. So it would be worth having a look at your neck as well, and just seeing if that's contributing to your headache symptoms, because that's something you may be able to help to try and reduce symptoms in the near future, because crying baby will certainly increase your migraines.
Okay. Hey team, do we have some other questions, or are we just about wrapping up? Okay, now just going to double check our questions that we had over there. There was
core strength.
Yes, that's right. Okay, we had one other question around, in your opinion, what's the importance of core strength in reducing or preventing back pain?
There's quite a few controversies here. Firstly, core strength has been our catchphrase for low back pain for the last 2 decades, no doubt. When you, however, look at the research, and this came about because I was talking to a spinal surgeon, in fact, maybe 5 years ago, and he did a clinic with me regularly, and we used to see complex patients, and we just he started recommending it, and I sort of asked him, "Oh, what's the evidence on it?" And he says, "Oh, no, I'm pretty sure it's good." So I went back and had a look at the evidence and looked at all the literature. So there's very large studies of 300 people, which is quite large for medical studies. And what they show is that so with randomized control trials, you'll get often two groups, and you'll get one group to do something and maybe one group to do something else, and then we'll measure how well they do over 3 months. So there was a couple of studies, and what they did was ultrasound guided core strength training versus just exercise in the gym, just prescribed exercise of any type. And what they found is, in fact, both groups improved about 20 or 30%, but there was actually no difference. So I think my overall advice would be to ensure that you actually get moving and exercise regularly 3 or 4 times a week if you have back pain. And really the benefit you may get from sort of directed core strength beyond that is probably not going to be amazing. And the other thing that I can say with honesty is that 95% of the people I see with low back pain are thin. In fact, they're active, thin, they exercise regularly. And if core strength was the source of low back pain or significant determinant, I would suspect that I would see people who are very obese with low back pain. But in my practice, that's certainly not the case.
Oh, that would be another interesting area to explore a bit further. Okay, hey, look, I think that's our time's just about up. Hey, thank you all so much for joining us. This is a topic that we could talk about all evening, as there are just so many different facets to it. But look, if you want to look at some books, Giresh has got some great books here around fix your neck pain, headache and migraines. This is one I've found great for patients, Fix Your Back as well. So do have a look at those, and we'll put the links on the Facebook. And there's also a lot of great resources around managing chronic pain on the Health Navigator website. So you do go and have a look there, including a pain toolkit that's been developed and translated into a number of different languages, which was developed by patients, and this was their experience of living with chronic pain. And it's the things we've talked about around relaxation and pacing yourself and the pain cycle, and medications don't do a lot, so you've got to help yourself. So
if I could just have one small plug, not to railroad things, but if people are listening, could they maybe go on to fixyourstress.com, which is my website, and email me? One of the initiatives we're looking at with the New Zealand Pain Foundation, which is a charity I started a few years ago, is looking at setting up chronic pain support groups nationwide. And so it'd be good to engage with some patients out there who might be listening, and email me your thoughts on it, because we're sort of having some meetings soon to look at starting a pilot somewhere and seeing A, if there's a need for it, and B, what the response would be. But I think it may help the social isolation there, and that a lot of people with chronic pain may fall into.
Great.
Thank you, Janine.
Okay, hey, look, we'll put the link for that as well on the Facebook. Hey, thank you all so much for joining us, and we look forward to seeing you next time. Thank you.
Cheers.
Bye.
Goodbye.